Atrial fibrillation is the most common cardiac dysrhythmia that we see in clinical practice. It may cause a patient to be breathless, to have a loss of exercise tolerance, to feel palpitations, but most importantly it puts them at a 5-fold increased risk of stroke.
It was really a big shock. The average person, I would assume, like myself, would not realise just how potentially dangerous it can be to have an irregular heartbeat.
I think there are gaps in the patients where we detect atrial fibrillation because detection of atrial fibrillation isn't easy. Atrial fibrillation can be a paroxysmal condition, it can come and go, and if you're not looking for it at the time that it's present, it could be easy to miss it.
Atrial fibrillation is a very important condition. It has a number of complications. It increases the risk of death roughly 1.5-fold, but the most feared complication is stroke, and it increases the risk of having an ischemic stroke 5 times. Atrial fibrillation causes roughly 20 to 30% of the ischemic strokes that we see. We also pick up another burden of atrial fibrillation in our subsequent investigations. Interestingly, atrial fibrillation doesn't always cause symptoms in our patients, and it's also important to recognise that the risk of the complications that concern us aren't actually related to whether or not the patient suffers symptoms.
I was getting ready for bed about 11:30 in the evening, and suddenly, without any warning, felt my left arm become really heavy from the elbow down. It seemed as though it had 3 or 4 times its normal weight, and I'd lost control of the movement of it, so I was, for instance, missing my ear if I was trying to scratch my ear. So I realised that this was something problematic. My mum had had a stroke and I'd seen her have that, so I realised that loss of power in the limb, loss of control was quite a dangerous sign.
In health we have efficient contraction around the heart, the left atrium contracts and we have smooth flow of blood. In the condition of atrial fibrillation, the electrical conduction is disorganised, the atrium fibrillates but there's no contraction. And we remember from basic pathophysiology, if you have stasis of blood, you have the potential for thrombus. Thrombus forms in the heart, and then in some situations that thrombus breaks off and travels into the systemic circulation. When that happens, in about 90% of cases it travels to the brain, causes ischemia and causes stroke.
Atrial fibrillation-related strokes are by and large more severe than the other types of ischemic stroke that we see. To give some examples, some studies have shown that they have far higher rates of disability, far lower rates of returning to independent living at 1 year, and in fact in one study 80% of patients with an AF-related stroke had died by 5 years.
I had been diagnosed literally 6 days before the stroke. I had had a couple of quite major chest infections which had really floored me, and at the second consultation with my GP he took my pulse and remarked that it seemed a bit irregular. Because as a layperson I didn't think anything of that. Now I know that's much more serious than I realised at that point. So they did say to me that over the next 10-year period there was a 1 in 20% chance that I could potentially have a stroke, but of course I wasn't anticipating it would be 6 days later.
Whichever metric you want to look at, an AF-related stroke causes more initial neurological disability, it's more likely to cause mortality, stay in hospitals longer, and it's more likely to be associated with institutional care. The reasons for that aren't entirely clear, but we believe it may be related to the formation of collaterals. In a large vessel stroke, there's a state of chronic ischemia, and the brain can compensate for that by forming collaterals. In atrial fibrillation, the very sudden onset of the thrombus, the brain hasn't had time to compensate for that. Atrial fibrillation strokes cause disabling stroke, but the good news is we have effective treatments for that. Thromboprophylaxis with an anticoagulant stops that initial formation of the thrombus in the heart, and so you don't then run the risk of systemic embolization. Thromboprophylaxis prevents systemic embolism by preventing the formation of the thrombus in the first place. We have the fibrillating heart, there's the substrate for forming thrombus, particularly around the left atrial appendage, but by keeping the blood thin, if you like, you don't have that nidus, and you don't have that thrombus forming.
I think it's really important that the condition is diagnosed quickly. I didn't really realise the potential ramifications of having an irregular heartbeat, but I had no idea just how potentially lethal it could be for the heartbeat to be irregular. It's important to be on medication that reduces the risk, because I certainly don't want anything like this ever to happen again. I would like to live for a long time.
Join us next time when the cardiologists discuss identifying risks for paroxysmal and persistent atrial fibrillation.
Doctors need, I think, to be more switched on to the possibility of atrial fibrillation. We need to be better at identifying it in patients who present with symptoms, or perhaps just picking it up routinely as we check a pulse, as we check a blood pressure. And importantly, once we detect atrial fibrillation, we need to confirm the diagnosis either with an ECG or a cardiac monitor, and then we need to rapidly initiate the appropriate treatment, the thromboprophylaxis. The trend for AF-related stroke is unfortunately very much on the up. We estimate that in the first half of this century, the prevalence of atrial fibrillation in the Western world will double. We therefore expect to see far more strokes caused by atrial fibrillation. The impact of the ageing population on AF-related stroke is very, very, very important. We recognise that roughly 1 to 2% of the general adult population have atrial fibrillation, but that's roughly 5% at retirement age and say around 10% at the age of 80. So the higher the numbers of patients above the age of 80, the more atrial fibrillation we will see. Atrial fibrillation, I don't know if you've ever heard of that.
To improve the prevention of AF-related stroke, there are really two things that are key. The first is detection, and the second is prescribing evidence-based therapy. For detection, there's still work to be done. Detecting atrial fibrillation isn't easy. It's often a paroxysmal condition, and a 12-lead ECG at one point of time may not pick up that atrial fibrillation. But we have other technologies, and we have ways to offer more prolonged monitoring of the heart to look for atrial fibrillation. In patients who've already had a stroke, we really need to work hard to make sure they don't have recurrent stroke. We know that recurrent stroke is associated with really substantial disability. Part of that is looking for atrial fibrillation. Atrial fibrillation may not have been obvious at the time of stroke, but we know that at least 25% of people with stroke have an atrial fibrillation-related stroke, and we know that that's treatable. So we need to work harder, we need to work smarter at looking for atrial fibrillation, and then when we find it, we need to act on that, and we need to prescribe thromboprophylaxis.
Clinicians decide whether to treat patients with atrial fibrillation based on the underlying risk of that person having an ischemic stroke. There's a trade-off between the benefit you get from using thromboprophylaxis and the risk of causing bleeding episodes. So we try to identify using scoring algorithms in whom that risk-benefit ratio is most favourable. When a clinician sees a patient with atrial fibrillation, they would typically perform a clinical risk assessment using something like the CHADS-VASc score. So this is a clinical scoring instrument where points are given to patients if they have other risk factors for stroke, if they have a previous history of stroke, and also based on their age. So if you calculate a CHADS-VASc score on a patient, if you have a score of 2 in men or 3 in women, it's advised that you use thromboprophylactic therapy unless there's a very clear contraindication. If the score is 0, we wouldn't offer thromboprophylaxis because that patient has a low risk of stroke. Roughly speaking, the benefit they would get is the same as the harm from using the medication. If the score is intermediate, so 1 in a man or 2 in a female, we would consider thromboprophylaxis on the basis of the patient's preference and perhaps their individual circumstances. We assess bleeding risk with thromboprophylaxis in the same way that we assess the ischemic stroke risk. We use a clinical scoring algorithm. There are several available, but one that perhaps is most widely used is the Hasbled score. And again, this assigns points for risk factors for bleeding and allows you to estimate roughly how likely that patient is to have a bleeding episode during thromboprophylactic therapy. We tend not to use the score as an arbiter of whether we prescribe or not. We use it as something that raises our consciousness to the potential risks and side effects. So for example, we know that if somebody has a score that's high of say 5 or more, they may have a risk of bleeding of around 10%. But even in that patient there may be a benefit. So it would switch us on to looking at what's reversible, what components of the score can we address, can we do something about, and we would implement those other treatment strategies, but still go ahead with thromboprophylaxis.
So the guidelines are very clear that we should be anticoagulating people who have atrial fibrillation and are at such risk that they warrant anticoagulation. And that's the majority of people with atrial fibrillation. For around 50 years, we really only had one option, and that was the vitamin K antagonists. We now have new drugs that have came online that seem to have differing risk-benefit ratios, and so there are many options open to the clinician.
Join us next time when the stroke specialists review the pros and cons with different anticoagulant agents.
If a patient has atrial fibrillation and we don't use thromboprophylaxis, that person remains at very high risk of having an ischemic stroke. We know that thromboprophylaxis data from the United Kingdom suggests that if we anticoagulated everybody that was eligible, we could save in excess of 7,000 ischemic strokes per year and 2,000 deaths per annum. Not all patients with AF receive anticoagulant therapy. A large piece of work recently showed that in the United Kingdom, only 4 in 10 patients who presented to an acute stroke unit with atrial fibrillation and an ischemic stroke were on anticoagulant therapy. The reasons why patients with atrial fibrillation aren't receiving anticoagulant therapy are quite difficult to identify. First of all, that patient may not have been known previously to have atrial fibrillation. It may have been the first diagnosis. Otherwise, we recognise that clinicians are fearful of the side effects. So sometimes we don't prescribe anticoagulants because of concerns about falling, previous bleeding episodes. Traditionally, we've used vitamin K antagonists or warfarin for thromboprophylaxis in atrial fibrillation, and that was really our only option until really the past decade. While vitamin K antagonists can be difficult to use, these are extremely effective medicines. We've known for quite some time now that warfarin reduces 2/3 of the strokes that would happen in a patient with atrial fibrillation. It's well tolerated by patients, but the main risk of warfarin is bleeding episodes. Because we can't predict on an individual basis which dose a patient will require, they have to have a loading regimen where we monitor them very, very closely, but we also need to keep monitoring patients in the longer term. This therefore necessitates lots of visits to the hospital, lots of contact with medical staff.
Simon Wheeler had a stroke on a flight to Singapore this year. Although his stroke was not caused by atrial fibrillation, he's now on warfarin once a day to reduce his risk of further stroke.
When I was in hospital, they were doing the INR tests daily and adjusting the warfarin levels appropriately. Since then, I've been going to outpatients anticoagulant warfarin clinics where on the spot they do an INR check. And then my warfarin doses for the coming days are either maintained at an existing level or adjusted. For the first couple of weeks, I was attending those every 3-4 days. It then went down to weekly, and that's what it is at the moment. My warfarin levels have never quite reached a point where it's, you'll just take 4 milligrams every day from now on and we'll never adjust it. So there has been a continual process of tweaking those warfarin doses up and down.
For many patients, the monitoring can be burdensome, but perhaps more importantly, there are numerous drug and food interactions, which means there's always some uncertainty about how good the person's long-term anticoagulation will be. We recognise with the warfarin-treated patient that during periods of under-anticoagulation, they are at higher risk. During periods of over-anticoagulation, they're at higher risk of bleeding episodes.
So for many years, aspirin was used for thromboprophylaxis in AF, but our understanding of the pathophysiology of atrial fibrillation has changed, and our understanding of the place of aspirin has changed also. We believe that aspirin would be safer, but would still provide some protection against thromboembolic stroke. We know now that both of those are perhaps not true. Aspirin is associated with morbidity and mortality, and aspirin doesn't seem to prevent thromboembolic stroke from the heart. In Glasgow, we had a look at primary care data, and we found that despite the guidance, there's still a large proportion of patients being given aspirin, anything up to 20 or 25%. In most cases, if someone has been prescribed aspirin solely as thromboprophylaxis, I would recommend changing to an anticoagulant.
So the difficulties with using warfarin created really quite an important clinical need. That need has been filled over the past decade or so by 4 novel oral anticoagulant drugs that are now available in most healthcare systems. The novel oral anticoagulant drugs have a number of potential advantages. These are bespoke new pharmaceutical compounds. They have much more specific mechanisms of action. They have much more predictable pharmacokinetics. So that allows us to use fixed dosing strategies for the majority of our patients, and the relationship between the drug concentration and the degree of anticoagulation is much more predictable than in use of warfarin. There are fewer drug interactions. There are some drug interactions, but far fewer, and they are much more predictable. So generally speaking, they are much easier drugs to use. Broadly speaking, they are similarly efficacious to warfarin in reducing the risk of an ischemic stroke or a systemic embolism. So remember, that means these drugs are very effective, given that warfarin already removes 2/3 of the strokes that we see. The other very consistent message that comes out from the trials is that each of the drugs gives roughly a halving of the risk of the most severe complication with anticoagulant therapy, and that's an intracranial hemorrhage. Most guidelines now suggest that we should utilise the NOACs as our first-line treatments in patients with atrial fibrillation who are candidates for thromboprophylaxis.
If there's something that can be done that can reduce my risk of having a further stroke, it would seem ludicrous not to be taken up. My concerns are how much it will affect my life continuing into the longer-term future.
Join us for the next episode when cardiologists evaluate various anticoagulants to determine optimal strategies for stroke prevention.
We need to look very rigorously for atrial fibrillation in our stroke patients, because we know that the harder we look, the more that we see. And we also know that treating atrial fibrillation with anticoagulant drugs is one of the most effective strategies for reducing the subsequent stroke risk. Every patient should have ECGs done on presentation, and they should all have telemetry while they're in the acute stroke unit, so cardiac monitoring done on a continuous basis, and that should be followed up if AF isn't detected by long-term monitoring as an outpatient.
Clinicians should consider the presence of atrial fibrillation in patients that they see with stroke, but we know that at least 25% of people with stroke have an atrial fibrillation related stroke, and we know that that's treatable. So we need to work harder, we need to work smarter at looking for atrial fibrillation.
Guidelines suggest to us that every patient should have an ECG to detect atrial fibrillation, and that they should have a form of more prolonged cardiac monitoring. Guidelines aren't entirely specific about what that means, but in clinical practice, most centres will do at least a 24-hour Holter monitor, so an ambulatory ECG, perhaps a 72-hour monitor where the resources are available, and we should then select out a subgroup of patients who we still haven't found atrial fibrillation, but we're concerned it may be there for more prolonged external or implantable loop monitoring. Long-term monitoring detects more atrial fibrillation because often the atrial fibrillation is paroxysmal. The atrial fibrillation may only be there for a period of minutes, and it comes scattered intermittently throughout a person's day, week or month. So the longer you look for, the higher the probability of detecting the episode. A 24-hour Holter monitor as an outpatient might detect AF in 11% of patients, but a 72-hour monitor may detect at least 1.6 or perhaps 2 times as many cases of atrial fibrillation. So we need to look as hard as we can afford to look for. Roughly 25 to 30% of our patients have cryptogenic stroke. These are patients who've been through a comprehensive diagnostic pathway, but a specific underlying cause for the stroke hasn't been detected. If we investigate these patients very thoroughly, we know we'll detect atrial fibrillation in perhaps 1 in 10 or even more of those patients. So if we find atrial fibrillation in a stroke patient, that patient would be a candidate for anticoagulant therapy unless there was a very clear specific contraindication.
As we realise the importance of anticoagulation and atrial fibrillation, we've been strongly encouraged to look at our patients and see how many patients with atrial fibrillation perhaps aren't on anticoagulation that should be. And there's still a lot of work to be done there. Within Glasgow, we work with colleagues in primary care to look at anticoagulation and atrial fibrillation. So we took all the patients with stroke and atrial fibrillation and we looked at their prescribing. What we found was that the majority were not given anticoagulation, and actually as the risk of AF-related stroke increased, the proportion given anticoagulation decreased. To my mind, as someone that works with people who've had a stroke, what was very important for me was just seeing the consequences of an AF-related stroke. And I think if other people realise how disabling and how devastating an AF-related stroke can be, that would change their prescribing, and it would really make them think about anticoagulation whenever they see atrial fibrillation.
We would assess the risks and benefits of starting anticoagulation after an ischemic stroke by looking at the degree of the clinical stroke severity, by looking at the volume of infarction on a CT scan, and looking at blood results and other comorbidities that would help us decide on their overall bleeding risk. The timing of anticoagulation initiation after an ischemic stroke can be difficult. We recognise that the risk of ischemic stroke is highest early, so we have a natural preference to start the drugs as soon as possible, but the hemorrhage risk is also biggest early after stroke. So there is some debate in the literature, and there remains clinical equipoise about the exact time of starting. Generally speaking, we would be happy to start anticoagulant drugs early in a mild stroke or a patient with a small volume of infarction who has a low bleeding risk, but we would wait perhaps anything as much as 2 weeks in a patient with a big volume of infarction or perhaps a big clinical deficit. Anticoagulant drugs in AF stroke patients are as effective as they are in other settings, so roughly 2/3 of the strokes, recurrent strokes we would see, will be prevented. What's important is that these people are at much higher risk because they've already had a stroke episode, so a 2/3 reduction in these patients is highly valuable.
Join us for the next episode when physicians discuss education strategies to help boost adherence.